Assalamualaikum and hello everyone. I am Dr. Harisa Hussaini Hasbullah, a clinical oncologist at UITM Hospital in Punjab. I will take you through the role of radiotherapy in thyroid cancer. Most of the material mentioned in this video is from this paper. One of the author, Dr. Vincent Gregoire, is a renowned head and neck radiation oncologist. So other references included those from internationally referred to guidelines, especially that from the American Thyroid Association. For those of you who are interested to read more about thyroid cancer, you're more than welcome to visit their webpage as well as this article as mentioned. So just to recap from previous lectures, there are essentially 4 different types of thyroid cancer. You have differentiated thyroid cancer consisting of papillary or follicular thyroid cancer, which carries the best prognosis among all different type of thyroid cancer. Then there's medullary thyroid cancer and the very aggressive anaplastic thyroid cancer. So the role of radiotherapy in thyroid cancer really depends on what type of thyroid cancer that the patient has. So for differentiated thyroid cancer, as mentioned in a previous slides, generally surgery followed by adjuvant radioiodine treatment can cure most of the patients with this type of cancer, provided surgery successfully removed all the tumor and patient has no distant metastasis. Patient also often require thyroxine, either as adjuvant or hormone replacement therapy. The role of adjuvant radiotherapy is controversial in differentiated thyroid cancer because of lack of complete data to support its use. Some would follow the Italian guidelines, which consider adjuvant radiotherapy if the disease has a high-risk features such as extrathyroidal extension or locally advanced disease, or has positive notes at presentation. But generally, we don't administer adjuvant radiotherapy in differentiated thyroid cancer patients who have had complete surgery and adjuvant radioiodine treatment for as long as subsequent whole body scan and serum thyroglobulin showed disease has been completely irradiated. So just to recap, most of differentiated thyroid cancer can take up radioiodine even at recurrence, and thus radioiodine treatment usually is sufficient in these patients. However, a certain percentage of differentiated thyroid cancer patients may be radioiodine refractory, which usually occur at recurrences following multiple treatment with radioiodine treatment. Radical radiotherapy therefore becomes important in cases like this, which whereby the disease doesn't light up on radioiodine whole body scan, but can be visualized clearly on a PET scan, as can be seen here. So these are images from a patient of mine who was diagnosed with papillary thyroid cancer in 2013, had surgery at that point in time, followed by radioiodine treatment. So his disease was initially under control, but a few years down the line, he had recurrences at tumor bed and in the neck nodes area as well. So to cut the story short, he had several other surgeries and several other radioiodine treatment up to a point where the disease became radioiodine refractory. So a PET scan light up like this, and eventually 5 years down the line in 2018, we gave him a radical dose of radiotherapy to control the disease. So for those of you who are interested to know how radiotherapy is being delivered, I have a video on this in a different MOOC. The address is shown here. Even though the video is on how radiotherapy is being delivered in colorectal cancer, but the basic principle of delivering radiotherapy in thyroid cancer is essentially the same. At undergraduate level, you do not need to know the detail of how radiotherapy is being done, but it's nice if you have at least seen how it's being done at least once or in a video. So if a patient asks in the future about radiotherapy, then at least you have some idea what to tell them. So as mentioned before, the process of radiotherapy in thyroid cancer is generally the same as with all other cancer. It starts with scanning using a CT scan compatible with radiotherapy machine. For thyroid cancer patients, they require a special mask to hold their head still throughout the treatment. This is followed by planning by physicists and then the plan reviewed and approved by oncologists to ensure that the target area get the maximum dose possible without damaging nearby critical structure. For example, in thyroid cancer, we want to keep the dose to the spinal cord below 45 gray. So once everyone is happy with the plan, patient is called for treatment. Now, doses of radiotherapy varied with different reason and indication, but generally, if we're treating it with a curative intent, then the typical dose that we gave when the gross disease is visible is between 66 gray to 70 gray, and these doses are split into 2 gray per fraction, meaning radiotherapy is protracted over 6 to 7 weeks duration. So usually the patient would need to come for treatment every day, Monday to Friday, until they complete the treatment over that 7 weeks duration. Okay, but the treatment itself usually takes only about 15 minutes or so. Right, so let's now move on to the second type of thyroid cancer, medullary thyroid cancer. In contrast to differentiated thyroid cancer, majority of medullary thyroid cancer patients have palpable neck nodes at presentation, and so surgery for this type of cancer usually involves both thyroidectomy and neck dissection. Because the tumor does not take up radioiodine, adjuvant radiotherapy is generally recommended in this setting to reduce risk of local recurrence. In cases of metastatic medullary thyroid cancer, targeted treatment is usually used, but in area where it is too expensive for the patient to obtain the treatment, then chemotherapy is a second choice in this kind of situation. Last type of thyroid cancer is the anaplastic thyroid cancer, which is the most aggressive and fast-growing of all types of thyroid cancer. So management of this type of cancer is multidisciplinary. Now, this is a flow diagram from the latest guideline from American Thyroid Association webpage. It looks complicated. You don't need to remember every single words on this diagram, but I will simplify the diagram for you, and I will take you through the diagram. So upon diagnosis of anaplastic thyroid cancer, very quickly patient need 2 things done urgently. Firstly, they need a full staging of the cancer, either with a PET scan or whole body CT scan, including the brain. And secondly, you need to do a genetic testing on the sample of the tumor, looking for a specific genetic mutation. So let's say after the staging, it is found that the disease is pretty much resectable, okay, localized and resectable. So then you would go for surgery, followed by adjuvant radiotherapy. Usually we give it together with chemotherapy. So it's called concurrent chemoradiation. If, however, the disease is more locally advanced, but the surgeon says that this is resectable, then again, surgery first, followed by adjuvant concurrent chemoradiation. But if the tumor is not resectable, okay, generally we would proceed with radical, definitive, concurrent chemoradiation. Another option is if the patient have a kind of BRAF mutation or NTRK mutation or RET fusion gene, then we would offer targeted therapy or some sort of targeted therapy. And if the tumor do respond, have excellent tumor response and surgery is possible, then you proceed with the surgery and again followed by adjuvant concurrent chemoradiation. If, however, the tumor doesn't respond well enough for to enable surgery, but radical radiotherapy is still possible, then that is something that we do. If radical surgery or radical radiotherapy are not possible, then it's pretty much palliative intent for the patient. Okay, so similarly, if upon staging, so we found that the disease is already metastasized to other parts of the body, but if the airway is compromised, sometimes we give a radical radiotherapy with a palliative dose to the thyroid area to prevent airway obstruction, and then followed by systemic treatment. If, however, airway is not compromised, then sometimes we just proceed with systemic therapy, and usually with a targeted therapy. If, however, the patient is not in a good condition to receive any form of systemic therapy, then best supportive care would be an option in this situation. So remember, in thyroid cancer, whether or not radiotherapy is beneficial or not, it depends on the type of the thyroid cancer that the patient has. So I hope that this video helps to give you some insight into the role of radiotherapy in thyroid cancer. I am contactable for any questions related to this if you have any. Thank you for your attention.